Welcome. We hope you enjoyed our presentation on glycemic control during cardiac surgery as part of the SCA's Fellowship Lecture Series. I'm Adam Evans, and I'm joined here with Dr. Jeffrey Mechanick, co-presenter and past president of the American Association of Clinical Endocrinologists, as well as professor of medicine and division director of metabolic support here at the Icahn School of Medicine in Mount Sinai. I'm going to be interviewing Dr. Mechanick now for the next couple of minutes to supplement the presentation that you just saw. Dr. Mechanick, thank you for being here with us.
My pleasure.
So let's get started. Dr. Mechanick, we know there is a lot of good data out there to support post-operative glycemic control in patients' status post-cardiac surgery. The data is now starting to emerge on the need for good control intraoperatively. Can you explain to us more why we should be focused on controlling blood sugars in the operating room as opposed to the ICU as well?
That's actually a really good question. If you look at glycemic control just in the post-operative period, then you're going to run into problems with a fair amount of people who are going to roll into the ICU with very high and uncontrollable blood sugars, and then no matter what protocol you have, it may be a lot more difficult to get them under control. So what we do is we zoom out on the problem a little bit, and we try to understand why patients actually have hyperglycemia in the ICU. One of the reasons is because of the stress that's going on in the operating room. Of course, another reason might be that they actually have type 1 or type 2 diabetes before they even have the procedure. So it makes perfect sense that if you really want to optimize glycemic control in the ICU, you would start focusing on glycemic control actually in the operating room.
Focus on intraoperative control. What do you see as the obstacles for providers in terms of maintaining glycemic control in the operating room?
Right, so thanks, Adam. This has actually been looked at in the past. There was a study at Mayo Clinic, which many of you may be familiar with. When you talk about any kind of a protocol in a hospital system, you're dealing with complexity with patients, and you're also dealing with complexity within the social or cultural environment in the hospital, and the operating room is no different. So it's one thing to come up with a protocol that's theoretically sound and you think it's going to work. It's another thing to come up with a protocol that can actually be implemented. For instance, you need to have all the anesthesiologists on board, the surgeons have to be on board. You have to have a protocol that's not going to be so time-consuming, and so it can't be logistically so difficult that it can't be done with all the other expediencies and pressures that are going on in the operating room. So for instance, the protocol that we use here that seems to work very well is one that doesn't have such a tight glycemic target, relaxes it a little bit between maybe 100 and 200, and doesn't have a lot of pressures for very frequent sampling of blood sugar, but sampling that's at appropriate times. Also, the calculations and computations that go into the insulin are not of the same order that we see in the ICU. In the ICU, they're second-order equations because they're based on the current blood sugar, the previous blood sugar, the current insulin rate, and they may even be third-order equations depending on the scenario and interruptions. Whereas in the operating room, they're first-order equations based on the blood sugar. You give a certain amount of insulin, and that's because you're dealing with a truncated period of time, a relatively short period of time measured on hours compared to the ICU, which is measured on days, maybe even longer.
Thanks for that answer. Is there anybody that we should screen for and can predict that will be difficult to control in the operating room?
Right. So in the operating room, again, just like we're looking at the operating room to better manage patients in the ICU, it would make sense to look at patients preoperatively to better manage them in the operating room with the intent to better manage them after surgery and have better overall outcomes. So what kinds of patients in the operating room would pose challenges? Well, certainly patients that are on steroids, patients that have type 1 diabetes, perhaps they were on an insulin pump and they now have to be transitioned off, patients that were out of control preoperatively. That's one of the reasons for checking an A1C routinely, not even just in patients with established diabetes, but all patients, because many patients who are rolling through this process have occult diabetes. They never knew they had diabetes. So you have an A1C and it can identify a patient who is now newly diagnosed with diabetes, an A1C greater than 6.5, for instance, or a patient with diabetes that was never understood to have just very poor control. We've had patients who all of a sudden come in, particularly if it's an emergency procedure and their A1C is 10, 12, even as high as 14. Those patients pose very particular challenges, and that's why it's important to have protocols in place.
Great. So we're very focused on treating hyperglycemia during cardiac surgery, and we anticipate that most patients who are on bypass will have a stress response. Having said that, there are a certain percentage of patients that are hypoglycemic during bypass. Should we be concerned about those as it relates intraoperatively into the postoperative period?
Well, this brings up actually 2 points that are very interesting. First is the detection of frank hypoglycemia, and second is the detection of an inappropriate euglycemia. So under periods of stress, with all of our physiologic programming as a result of evolution, and this is Darwinian evolution, the normal response is to have some element of hyperglycemia. Failure to have that hyperglycemia, at least in theory, one might think would not be good. Now, we've demonstrated that in a clinical series here at Mount Sinai, that failure to manifest stress hyperglycemia increased your risk of mortality actually in the postoperative course. Frank hypoglycemia is also something to worry about. And there are two types of frank hypoglycemia. There's the type of hypoglycemia that results directly from the insulin therapy. And there's the other type of hypoglycemia that may result from having pretty significant organ dysfunction. It's that latter type that is probably more associated with a worse outcome. In addition, this gives me an opportunity to mention the independent effects of glycemic variability. So it's not just the average blood sugar, which is the prime determinant of outcome, but really these fluctuations of blood sugar from say 40 to 400, even though the average might be in the 100s of a situation like that, it's much better for a patient to have more consistent blood sugars, perhaps at a higher average blood sugar, than to have a perfect average blood sugar, but that average as a result of wide fluctuations. So you can see this is a little bit more complicated than simply just measuring sugars. Physicians need to be sensitive to avoiding very high blood sugars, avoiding very low blood sugars, and also avoiding those fluctuations that we term glycemic variability.
Great, thank you. So with all that said, can you give us an update on what you think the future holds for glycemic control during cardiac surgery?
Right, well this is always the magic question. Where are we going from here? So I think there's going to be three parts. The first is going to be culture, the second is going to be technology, and the third is going to be a philosophy, a different viewpoint. Culture means that everybody has to be on board. Hospital administrators have to be on board. The nursing team has to be on board, physicians, intensivists, anesthesiologists, surgeons, all of the consultants need to be aware that glycemic control is very important, because if there's a weak link, then the whole system can really unravel and be dismantled, and for all the good intents, you're still going to have patients who are going to be out of control. The second is technology. Closed loop systems are clearly on the horizon, where rather than going through all of these permutations and computations with pencil and paper or on the computer at the bedside, rather there are going to be catheters and telemetry and closed loop systems where these type of insulin adjustments are going to be done almost instantaneously based on some overarching parameters which will be inputted by the intensivist to maintain very good control with low glycemic variability. And third is a philosophy. Rather than just focusing on glycemic control independently, we again take a step back and we look at metabolic control or intensive metabolic support, necessarily including nutrition and other factors that affect the hypothalamus, the adaptation to stress, where glycemia is only one part of it. This is going to require research, and this type of approach will require validation, but that's the way that I would envision the future.
Well, Dr. Mechanick, thank you very much for your time
You're welcome.
today. Looks like we have a lot of work to do in this interesting area.